Welcome to MedCrush, the channel where we break down high-yield USMLE concepts into simple, easy-to-remember lessons. In this series, we'll focus on exam patterns, clinical clues, and core mechanisms that help you crush your USMLE prep. Today, we're starting with one of the most commonly tested renal topics, acute kidney injury. Acute kidney injury means the kidneys suddenly stop working the way they should. You'll see this as a rise in serum creatinine, a rise in blood urea nitrogen, and a drop in urine output, which we call oliguria. If you see this triad in a USMLE question, acute kidney injury should be your first thought. Acute kidney injury is classified into three major categories based on where the problem is occurring: prerenal, intrinsic renal, and postrenal. When you see acute kidney injury on a question stem, your first job is to localize the problem. Is it prerenal, intrinsic, or postrenal? Prerenal means low perfusion to the kidney. Intrinsic means the kidney tissue itself is damaged, and postrenal means there's an obstruction downstream. Once you classify the type, the diagnosis usually becomes straightforward. So first, let's look at prerenal acute kidney injury. In prerenal AKI, the kidney itself is structurally normal. The problem is decreased blood flow to the kidney, also called hypoperfusion. Common causes include dehydration, hypotension or shock, and heart failure. Because the kidney senses low volume, it tries to conserve water by reabsorbing more urea. This results in a high BUN to creatinine ratio, typically greater than 20:1, because urea is reabsorbed along with water, while creatinine is not reabsorbed. This is a classic USMLE clue for prerenal acute kidney injury. So on MCQs, if you see the BUN to creatinine ratio increase to 20 or more, you should first think of a prerenal cause of acute kidney injury. This diagram shows how low blood volume increases ADH release, which enhances water reabsorption in the collecting ducts. Urea follows water passively and gets reabsorbed, while creatinine is not reabsorbed. That's why the BUN to creatinine ratio rises in prerenal acute kidney injury. So after prerenal causes, the next category is intrinsic acute kidney injury, where the problem is within the kidney itself. Here, there is direct damage to the renal tissue, which can involve the tubules, the glomeruli, or the interstitium. On the USMLE, the two most commonly tested intrinsic causes are acute tubular necrosis and acute interstitial nephritis, which we'll go through next. Acute tubular necrosis can be caused by either ischemia or nephrotoxins. The renal tubules, especially the proximal convoluted tubule and the thick ascending limb, have a very high metabolic demand because they actively transport ions and require large amounts of ATP. This makes these segments particularly vulnerable to ischemic injury. Ischemic ATN is commonly seen in settings like shock, sepsis, or severe hemorrhage, where reduced perfusion leads to hypoxia and tubular cell death. Nephrotoxic ATN occurs when substances directly injure the tubules. High-yield examples include aminoglycosides and contrast dye. For exams, they love to test nephrotoxic ATN using classic toxin scenarios. For example, rhabdomyolysis may be tested as a patient with crush injury or prolonged immobilization who develops dark urine and acute kidney injury due to myoglobin-induced tubular toxicity. Ethylene glycol poisoning is often tested as antifreeze ingestion, with high anion gap metabolic acidosis and calcium oxalate crystals in the urine, leading to tubular injury. Recognizing these toxin patterns helps you quickly identify nephrotoxic ATN on USMLE questions. On urinalysis, acute tubular necrosis is characterized by muddy brown granular casts, which represent dead tubular epithelial cells sloughing off into the urine. In exam stems, muddy brown casts in the setting of shock or toxin exposure are a strong clue pointing toward ATN. Once acute tubular necrosis occurs, it classically progresses through three phases, and the USMLE loves to test the clinical features of each phase.
The first is the initiation phase, which occurs within hours of the initial insult, whether ischemic or toxic. This is when tubular injury begins.
Next is the maintenance phase, which typically lasts 1 to 2 weeks. This is the most dangerous phase, characterized by oliguria and rising serum creatinine. During this phase, patients are at high risk for complications, especially hyperkalemia, which is a major cause of mortality in acute kidney injury. Finally, the recovery phase occurs as the tubular epithelium regenerates. Patients develop polyuria because the new tubular cells are immature and cannot concentrate urine effectively. During this phase, electrolytes can be lost in the urine, so hypokalemia becomes an important complication to watch for. Recognizing which phase a patient is in can help you answer prognosis and management questions on exams. This diagram shows the muddy brown granular casts within the tubules. After acute tubular necrosis, another important intrinsic cause of acute kidney injury is acute interstitial nephritis. In this condition, the tubules are initially intact, but the problem lies in the interstitium, which is the space between the tubules. A hypersensitivity reaction leads to inflammation in this area, and the resulting edema compresses the tubules and impairs kidney function. On exams, AIN is classically associated with drug reactions and allergic-type mechanisms, rather than direct tubular toxicity. Here, a useful mnemonic is mentioned to help you remember the common drug causes of acute interstitial nephritis. These include diuretics, NSAIDs, penicillins and cephalosporins, proton pump inhibitors, and rifampin. Because acute interstitial nephritis is an immune-mediated process, the characteristic urine finding is white blood cell casts. You may also see eosinophils in the urine. Another important exam clue is steropyuria, which means white blood cells are present in the urine, but no bacteria grow on culture because this is not an infection. It's an allergic type reaction. On exams, the combination of recent drug exposure, white blood cell casts, and steropyuria should make you think of acute interstitial nephritis. This table summarizes the key differences between acute tubular necrosis and acute interstitial nephritis, which are the two most commonly tested intrinsic causes of acute kidney injury. In acute tubular necrosis, the primary problem is direct death of tubular epithelial cells due to ischemia or toxins. The classic urine finding is muddy brown granular casts. In contrast, acute interstitial nephritis is an immune-mediated process affecting the interstitium, most often triggered by medications. The characteristic urine findings are white blood cell casts and eosinophils, along with steropyuria. On exams, paying attention to the patient's history is crucial. A recent episode of shock or toxin exposure points toward ATN, whereas a history of starting a new drug 1 to 2 weeks earlier points toward AIN. Recognizing these patterns helps you quickly distinguish between these two intrinsic causes of AKI. Finally, the third category of acute kidney injury is postrenal failure, where the problem occurs after the kidney due to obstruction of urine flow. Common causes include bilateral kidney stones, benign prostatic hyperplasia, and tumors compressing the urinary tract. On exams, look for clues such as difficulty urinating, a distended bladder, or hydronephrosis on ultrasound. These findings point toward a postrenal cause of acute kidney injury. Recognizing obstruction is important because postrenal AKI is often reversible once the blockage is relieved. So to quickly recap the big three you need to know for the boards, prerenal is all about flow. Remember, the kidney is dry and thirsty. Intrinsic is about damage inside the factory. Watch out for those muddy brown casts in ATN versus the WBC casts and eosinophils in AIN. Postrenal is simply the blockage downstream. But here's the truth. Understanding the pathology is only half the battle. The USMLE trickery comes down to how you apply this in a question. That's exactly what we're covering in the next video, strategic approaches to MCQs. I'm going to show you how to differentiate these scenarios quickly so you can pick the right answer every time. If this helped clarify AKI for you, hit that like button and subscribe to Crush Med so you don't miss the MCQ strategy session coming up next. I'll see you in the next video.